Start.
Yes. Okay. Thank you. So, good evening. I'll be presenting a case of missed COVID MISC in a case of post-operative primary Fontan operation. We have a 14-year-old boy diagnosed with a CCTGA, large annular BSD, grade 1 straddling of AV valve and pulmonary stenosis. Saturation was 80% on room air. ECG showed sinus rhythm with intermittent ventricular ectopics. As per protocol, we had sent his COVID RT-PCR, which was negative. So we did a cardiac catheterization pre-operatively. PA pressures were normal. PVRI was 0.48 Woods units. BSD was not routable to the aorta, and AVBR was mild. Child underwent a Fontan surgery with a 5 mm fenestration. Now, during his post-operative period, he was stable for the first 6 hours on minimal ventilator support and inotropic support of adrenaline of 0.05 mics and normotermin of 5 mics. He was saturating at 94% with VO2s of 85. We were giving a FiO2 of 50%. Now, as time went by, we were having a lot of difficulties maintaining his Fontan pressures. He required very high volume intake to maintain his preload. Gradually, we started on vasoconstrictors. We had to start noradrenaline, and we even went up on his vasopressin up to 0.01 units per kilo per hour. Low cardiac output set in, he went into vasodilatory shock, and he had biventricular dysfunction. His chest X-ray showed no pleural effusions. There was a left retrocardiac collapse. So ECG, he had ventricular ectopics with a sinus rate of 120. His echo showed that he was this is a 4-chamber apical view, showed biventricular dysfunction. His IVC was underfilled, and this is his tissue velocity showing biventricular dysfunction. On post-op day 1, child developed multi-organ dysfunction with sepsis. When we look at this, these are his graphs. So this is his renal parameters. When we look at it, he is actually in significant renal failure, which gradually worsened. So his creatinine shot up to 6.6 and a urea of 166. At this point of time, we started on peritoneal dialysis, and he went into a complete anuric phase for some time. His liver functions also deteriorated significantly. His liver enzymes shot up to 8,000 plus, and his septic parameters were also very significant. If you see, his total whites were gradually going up, and his procalcitonin levels were very high, more than 100. Now we were thinking, what were we actually dealing with? Is it a Fontan failure? If really it was Fontan failure, it's true. The child was in biventricular dysfunction. There was no flows across the fenestration, and he was in multi-organ dysfunction. At this point of time, we were considering whether should we actually take down his Fontan, or should we even increase the size of his fenestration. But on the other hand, he did have vasodilatory shock as well. He had raised septic parameters. Fontan pressures were low, and his preload requirement was very high. Now, are we actually dealing with something else? That was a dilemma that we were facing. No clinical improvement, but on post-op day 3, he started developing conjunctival congestion with generalized rash and swelling of his extremities. We knew that he was anuric, his liver enzymes were already high, PCT was more than 100, and he started manifesting his coagulopathy. He started bleeding from his mediastinal drains. Echo showed pericardial effusion, and at that point, coronaries could not be visualized. Now, looking at this entire picture, are we actually dealing with COVID with MISC, marking the fact that we are within the pandemic? We had sent his inflammatory markers. Ferritin was, his inflammatory markers were actually pretty significant, and his COVID antibody titers were high at 148. We treated him with IV methylprednisolone for 3 days, and we tapered off his steroid doses. 3 days post his methylprednisolone, we actually checked his inflammatory markers again, and it's significantly improved. Now, overall, how did we actually manage this child? Ventilation went on for a good 1 week. We continued his inotropes, optimized his hemodynamics, started amiodarone infusion for his arrhythmias. Antibiotics, we upgraded to meropenem and colistin. Peritoneal dialysis really helped him through the first 2 weeks. Methylprednisolone made a change. And we started aspirin once his thrombocytopenia resolved. Eventually, his rash and conjunctival congestion settled by day 6. Inotropic requirement reduced significantly. We took off his vasopressors by post-op day 7, extubated the child by post-op day 7 as well. Though his cultures were sterile, we completed his course of antibiotics for a total of 14 days. Liver function and coagulation parameters eventually normalized. We had to continue his peritoneal dialysis for a good 15 days till his renal function normalized. Prior to discharge, his echo findings actually improved, his biventricular function improved, and he had good unobstructed flows through his fontan. So the take-home message is, in post-op cardiac cases, when we are dealing with unexplained sudden clinical deterioration, it's good to keep COVID-19 MIS-C behind in our minds. Keep a high index of suspicion always. Thank you.